Diagnosis of the distribution of chronic urethritis. Since it is not my custom to use the urethroscope in the diagnosis of gonorrhea, except in rebellious and protracted cases, I prefer to describe the routine method of examination followed at the patient's first visit, leaving the matter of urethroscopic diagnosis for subsequent discussion. Upon accurate diagnosis depends the patient's prospect of cure, and such diagnosis, even without urethrooscopy, may require several examinations. The patient presents himself with a history of chronic or relapsing urethral discharge, with shreds or pus in the urine, or with various sexual or painful symptoms. The first examination. The examination for gonococci already described takes first place. The routine examination of the lesion is as follows. 1. The meatus is examined for discharge and a smear taken for microscopic examination and inflammation. The urethra for nodules of periurethral infiltration. The testicles for evidence of epididymitis. 2. The patient then urinates in 2 glasses as described in Chapter 2. 3. A 16 French catheter is introduced. The site of pain, bleeding, or obstruction noted. Residual urine estimated, to be confirmed by subsequent examination, and about 100 cc's of saturated boracic acid solution injected into the bladder. 4. Prostate and vesicles are then massaged. Any expressed secretion is caught upon a slide for examination. 5. The patient then empties the bladder into 2 glasses, if no secretion has been expressed by massage, otherwise into 1. If residual urine is suspected, this is verified by measuring the amount passed. From this examination, we glean the following diagnostic points. Anterior urethritis, usually pus at meatus, second flow of urine clear, no abnormality felt in prostate or vesicles, no pus in the secretion expressed from these organs or in boracic acid solution. Posterior urethritis, no pus at meatus unless there is anterior urethritis as well. Clinically, there is almost always enough anterior urethritis to produce a morning drop. Second flow of urine may be clear or cloudy. Prostate and vesicles feel normal, but in the secretion, expressed or centrifuged from silver solution, there are a few pus cells. Prostatitis, same as posterior urethritis, except that indurations or abnormalities of contour are usually discerned in the prostate, and the expressed secretion is frankly purulent. There may be residual urine. Vesiculitis, same as prostatitis, except that vesicles are distended or indurated. Just as there is always prostatitis with vesiculitis, so there is often impalpable vesiculitis with prostatitis. The attempt to distinguish the expressed secretion of the two is likely to prove misleading, for though a large part of the vesicular secretion floats in urine, pus from the vesicle, like pus from the prostate, sinks. Stricture. Marked stricture obstructs or prevents the passage of the catheter. Slight stricture is not diagnosed until a subsequent examination. Cicatricial or prostatic obstruction at the neck of the bladder gives residual urine. Cystitis. It is probable that some inflammation of the bladder, or at least of the trigone, exists whenever the second flow of urine is purulent. But this cystitis is a negligible quantity that disappears long before the posterior urethritis is cured. Retention cystitis is, of course, important. Pyelonephritis. The diagnosis of gonorrheal pyelonephritis offers no peculiar difficulties excepting insofar as urethritis prohibits cystoscopy. The renal colic due to vesiculitis and the lumbar pain due to epididymitis are distinguished by physical examination. Object of this method of examination. The object of this examination is to obtain the maximum of information about the patient while doing him the least possible harm. By it, the precise lesion in the anterior urethra is not as accurately determined as though the urethroskop were used, but the risk of stirring up a urethra whose temper is not known warrants deferring this more precise examination to a subsequent date, the following day if the patient cannot be kept under observation, but preferably after a few days of treatment unless the case is very chronic and the temper of the urethra has already been well tested by others.